Holiday presents, in the red corner, the undisputed, undefeated Weed Whacker Guy. Champion of hurling grass and pollen everywhere. And in the blue corner, the challenger, extra strength Holiday. Eye drops that work all day to prevent the release of histamines that cause itchy allergy eyes. And the winner, by knockout, is Holiday. Holiday, bring it on.
Disney Plus wants to know, are you ready?
Yes!
For Marvel Studios' Thunderbolts, The New Avengers, now streaming on Disney Plus.
Let's do this.
One of the best Marvel movies of all time is now streaming on Disney Plus.
Hey, you weren't listening to me.
I said Thunderbolts, The New Avengers is now streaming on Disney Plus.
Meet the New Avengers.
That's a cool name.
Marvel Studios' Thunderbolts, The New Avengers, rated PG-13, now streaming on, you guessed it, Disney Plus.
This is Dr. Ted O'Connell with the Med Prep to Go Step 2 Qbank podcast. Today we'll be reviewing 3 renal questions. Just a reminder that you can find these questions and many more on our website at medprep2go.com. If you have feedback or you'd like to get involved in this project, please email me at ted.medprep2go@gmail.com. If you like what we're doing, please subscribe to the podcast, give us a review, and let your friends know about this content. All right, let's get started with the first question. A 72-year-old man is admitted to the hospital with severe sepsis secondary to a urinary tract infection. Past medical history includes hypertension, hyperlipidemia, benign prostatic hyperplasia, and squamous cell cancer of the skin. Despite aggressive fluid resuscitation, his urine output remains low. Laboratory results show a blood urea nitrogen, BUN, level of 40 milligrams per deciliter and a serum creatinine level of 3.0 milligrams per deciliter. Urinalysis reveals muddy brown granular casts and free renal tubular epithelial cells. The fractional excretion of sodium, or FeNA, is 3%. Which of the following is the most likely diagnosis? A, acute interstitial nephritis. B, acute tubular necrosis. C, glomerulonephritis. D, postrenal acute kidney injury. Or E, prerenal acute kidney injury. The correct answer is B, acute tubular necrosis. This patient has sepsis with persistence of acute kidney injury, or AKI, despite aggressive fluid resuscitation. Acute tubular necrosis, or ATN, is the most common cause of intrarenal acute kidney injury. The 3 major causes of ATN are kidney ischemia, sepsis, and nephrotoxins. The classic urinalysis of ATN reveals muddy brown granular casts and free renal tubular epithelial cells. The fractional excretion of sodium typically is greater than 2% in ATN. Fluid repletion will typically correct prerenal disease, while the AKI will persist in ATN. Answer choice A, acute interstitial nephritis, is incorrect. Acute interstitial nephritis typically presents with fever, rash, and eosinophilia, often in response to medications, and does not show muddy brown granular casts or a high FeNA. Answer choice C, glomerulonephritis, is incorrect. Glomerulonephritis often presents with hematuria, proteinuria, and red blood cell casts in the urine, which are not seen in this patient. Answer choice D, postrenal acute kidney injury, is incorrect. Postrenal acute kidney injury is usually caused by obstruction of the urinary tract and often presents with symptoms of urinary retention or hydronephrosis, which are not present in this case. Answer choice E, prerenal acute kidney injury, is incorrect. Prerenal acute kidney injury typically presents with a BUN to creatinine ratio greater than 20 and a FeNA less than 1%. Urinalysis typically is normal or near normal, with hyaline or fine granular casts that are sometimes seen. Fluid repletion usually corrects prerenal AKI, which is not the case here. The key learning point: acute tubular necrosis is the most common cause of intrarenal acute kidney injury. The three major causes of ATN are kidney ischemia, sepsis, and nephrotoxins. The classic urinalysis of ATN reveals muddy brown granular epithelial casts and free renal tubular epithelial cells. The fractional excretion of sodium typically is greater than 2% in ATN. Fluid repletion will typically correct prerenal disease, while the AKI will persist despite fluid resuscitation in ATN. Question 2. A 24-year-old man presents to the emergency department with a complaint of 1 day of painless, dark urination. He reports mild bilateral flank pain and denies joint pain and abdominal pain. He has no past medical history, but notes that he did have a sore throat a few days ago that resolved without any treatment. His only medication is a multivitamin and 5 grams of creatine daily. His father passed away from urothelial bladder cancer 2 years ago, and his mother has type 2 diabetes mellitus. He does not drink alcohol or smoke cigarettes. Vital signs include a temperature of 37.1 degrees Celsius or 98.6 degrees Fahrenheit, blood pressure 145 over 90 millimeters of mercury, pulse 90 beats per minute, and respirations 17 per minute. Physical examination shows mild pitting edema in his bilateral ankles. Complete blood count is normal. Serum creatinine is 1.5, which is elevated from 1.0 at his last primary care visit 2 months ago. Serum C3 and C4 are within normal limits. A urinalysis shows the following: blood 2+, protein 1+, nitrites negative, leukocyte esterase negative, white blood cells negative, white blood cell casts negative, red blood cell casts many, glucose negative, ketones negative. The urine protein to creatinine ratio is 1.8 grams per day. Which of the following pharmacotherapies is the most appropriate treatment for this patient? A. Cisplatin, B. Penicillin, C. Sparsentan, D. Tamsulosin, or E. Trimethoprim sulfamethoxazole. The correct answer is C. Sparsentan. Based on the clinical presentation and urinalysis findings, the most likely diagnosis is IgA nephropathy. The presence of hematuria, mild proteinuria, and red blood cell casts following a recent upper respiratory infection is highly suggestive of IgA nephropathy. This is a type 3 hypersensitivity reaction in which IgA immune complexes deposit within the glomeruli. The management of primary IgA nephropathy focuses on supportive care, which includes controlling blood pressure to optimal targets, smoking cessation, and limiting dietary sodium intake. For patients with IgA nephropathy and proteinuria greater than 500 milligrams per day, an angiotensin converting enzyme, or ACE inhibitor, or an angiotensin receptor blocker is indicated. Sparsentan is a relatively new FDA-approved drug for the treatment of IgA nephropathy and has a unique mechanism as both an endothelin antagonist and an angiotensin receptor blocker. Through these two mechanisms, sparsentan has shown to reduce blood pressure, decrease proteinuria, and protect the kidneys in IgA nephropathy. Sparsentan can be used for patients with IgA nephropathy and who are at risk of rapid disease progression, defined as a urine protein to creatinine ratio greater than 1.5 grams per day. Patients who are at high risk of disease progression, defined as proteinuria greater than 1 gram per day, may be given oral glucocorticoids. Answer choice A, cisplatin, is incorrect. Cisplatin is one of the drugs used to treat urothelial bladder cancer, which also tends to present with painless hematuria. This patient does have a family history of urothelial bladder cancer in his father, but his young age, lack of smoking or other risk factors such as azo dyes, and prior upper respiratory infection point more towards a diagnosis of IgA nephropathy. Answer choice B, penicillin, is incorrect. Penicillin would be the correct answer if this patient had post-streptococcal glomerulonephritis, or PSGN. PSGN presents similarly to IgA nephropathy, but occurs 1 week or more after streptococcal pharyngitis, whereas IgA nephropathy has an onset shortly after an upper respiratory infection. While both conditions can cause hematuria and elevated blood pressure, the time course of this presentation plus the normal complement levels point towards IgA nephropathy. Answer choice D, tamsulosin, is incorrect. There is no evidence supporting the use of tamsulosin, an alpha-1 antagonist, in the treatment of IgA nephropathy. It remains a staple of the treatment of benign prostatic hyperplasia. Answer choice E, trimethoprim sulfamethoxazole, is incorrect. Trimethoprim sulfamethoxazole would be an appropriate option if this patient had a urinary tract infection. However, he does not have painful urination or evidence of infection on a urinalysis, such as positive white blood cells, leukocyte esterase, or nitrites. The key learning point here: the management of primary IgA nephropathy focuses on supportive care, which includes controlling blood pressure to optimal targets, smoking cessation, and limiting dietary sodium intake. For patients with IgA nephropathy and proteinuria greater than 500 milligrams per day, an ACE inhibitor or angiotensin receptor blocker is indicated. Sparsentan, an endothelin antagonist and angiotensin receptor blocker, can be used for patients with IgA nephropathy and who are at risk of rapid disease progression, defined as a urine protein to creatinine ratio greater than 1.5 grams per day.
Hey everyone, Chris here from MedPrep to Go, and I wanted to tell you about our MedPrep to Go Step 3 review podcast that features over 90 episodes and 40 hours of high-yield content from Dr. Ted O'Connell and Dr. Raj Dasgupta. This is a premium podcast that has already helped over 100 students pass their exam. You can learn more and subscribe at medprep2go.com. Hey everyone, Chris here from MedPrep to Go, and I wanted to let you know about our premium Step 2 bundle podcast, which gets you all of the Step 2 secrets and our Step 2 questions podcast combined and ad-free. You'll also get early access to all of our Step 2 questions episodes before they're released public. The bundled podcast is available now, and you can save over 40% with an annual plan. Details at medprep2go.com.
Question 3. A 68-year-old man presents to the emergency department with confusion and lethargy for the past day. He has a history of end-stage renal disease and has missed his last 2 dialysis sessions. He also has a history of hypertension, secondary hyperparathyroidism, and hyperphosphatemia. His medications include lisinopril, empagliflozin, cinacalcet, and calcitriol. Vital signs are within normal limits. On physical examination, he is disoriented and has peripheral edema. Laboratory tests reveal a mild normocytic anemia, potassium level of 7.2 milliequivalents per liter, blood pH of 7.1, and significantly elevated blood urea nitrogen and creatinine levels. Which of the following is the most appropriate next step in the management of this patient? A. Administer intravenous calcium gluconate. B. Initiate emergency dialysis. C. Monitor and recheck labs in 24 hours. D, prescribe oral sodium polystyrene sulfonate, or E, start bicarbonate therapy? The correct answer is B, initiate emergency dialysis. Indications for acute renal dialysis can be remembered with the AEIOU mnemonic. A for acidosis, which is severe metabolic acidosis, usually with a pH less than 7.2. E is for electrolytes, specifically hyperkalemia that is typically greater than 6.5 milliequivalents per liter. I is for ingestion of a dialyzable drug or toxin. O is for fluid overload. And U is for uremia, symptoms of uremia such as encephalopathy. This patient presents with severe hyperkalemia with his potassium level of 7.2 milliequivalents per liter, severe metabolic acidosis with a pH of 7.1, and symptoms of uremia, including confusion and lethargy, all of which are indications for emergency dialysis. Answer choice A, administer intravenous calcium gluconate, is incorrect. While calcium gluconate can stabilize the cardiac membrane when hyperkalemia is present, it does not address the underlying causes requiring dialysis. Answer choice C, monitor and recheck labs in 24 hours, is incorrect. This approach is not appropriate given the severity of the patient's condition, which requires immediate intervention. Answer choice C, prescribe oral sodium polystyrene sulfonate, is incorrect. This can help lower potassium levels, but is not appropriate for immediate management of severe hyperkalemia and will not address the metabolic acidosis and uremia. Answer choice D, start bicarbonate therapy, is incorrect. Bicarbonate therapy may help with acidosis, but is not sufficient to address the severe hyperkalemia and uremia. The key learning point here, indications for acute renal dialysis can be remembered with the AEIOU mnemonic. A for acidosis, severe metabolic acidosis, usually with a pH under 7.2. E for electrolytes, specifically hyperkalemia. I for ingestion of a dialyzable drug or toxin. O for fluid overload. And U for uremia, including encephalopathy. Okay, so that's it for this episode, but please do check out our other episodes as well as all of our other content at medprep2go.com.
Hey everyone, Chris here from MedPrep2Go, and I wanted to ask you to please follow us on social. There may be links in the show notes, or you can find us at MedPrep2Go on Facebook, Instagram, LinkedIn, and now YouTube. We would greatly appreciate it as we try to spread the word about MedPrep2Go and keep medical education accessible and affordable. Do you need a break from studying? Check out the Dr. Raj podcast, where he discusses topics such as wine with Jesse Katz, sarcoidosis with Bob Saget, saving the bees with Sydney S. Sill, and so much more. The podcast also features guest host Becca Spar, who focuses on leadership and connection, as well as Dr. Michelle Kulai and her Everyday Rooms segment, where she talks to patients to share their stories and the challenges that come with different conditions. Just search for the Dr. Raj podcast wherever you're listening now and tune in for a variety of great guests and topics.